This patient is a 55-year-old male with paroxysmal atrial flutter with a rapid ventricular rate. Beta blockers were ineffective, and he desired catheter ablation. Informed consent is obtained from the patient while discussing the plan for the procedure as well as the risks involved. The patient is brought into the electrophysiology laboratory, and defibrillation patches, grounding pads, ECG leads, blood pressure cuff, oxygen saturation monitor, and three-dimensional mapping system patches, if used, are applied. The patient is then prepped in the standard fashion. Here we are entering only from the femoral veins, so the bilateral groins are prepped, though some operators may choose to access the internal jugular or subclavian veins as well. After prepping the areas for venous access, sterile draping is applied. The catheter cables are plugged into the appropriate locations in the mapping system computer or pin block to allow monitoring and recording during the procedure. The operator performs a sterile scrub and dons a sterile gown and gloves. The equipment needed for the procedure should be immediately available, including a local anesthetic, such as lidocaine, with needles and syringes, introducer sheaths of varying sizes, catheters, and associated cables. In addition, a recording system, pacing stimulator, and fluoroscopy are needed. Three-dimensional mapping system is optional, but may be helpful to reduce radiation exposure. In order to obtain venous access, first feel for the femoral artery, which then identifies the location of the femoral vein about 1 centimeter medial to the artery. Local anesthetic over the femoral vein is given at this point. Mild or deeper sedation can be used based on patient comfort. After adequate local anesthesia has been achieved, the femoral vein is accessed using the modified Seldinger technique. 3 access points are obtained in the femoral vein, about 3 to 5 millimeters apart. Ultrasound guidance may be desired for venous access because it allows entering only the anterior wall of the vessel, reducing the likelihood of post-procedural hematoma. After the wires are placed in the vein, the sheaths are inserted over the wires and secured in position. Once venous access is obtained, the electrophysiology catheters are inserted. Catheter placement can be monitored using fluoroscopy or with a three-dimensional mapping system. Depending on the 3D dimensional mapping system used, the ablation catheter may need to be inserted first into the right atrium to make an anatomic map of the chamber. A multipolar catheter, seen in blue here, is then advanced from the femoral vein into the coronary sinus. Another multipolar catheter, seen in teal here, is advanced into the right atrium and is placed around the tricuspid annulus. The goal of the procedure is to create a complete line of block between the tricuspid valve and inferior vena cava, called the cavo-tricuspid isthmus, or CTI, to prevent future occurrences of atrial flutter, as seen in this LAO caudal view. If the patient is in normal sinus rhythm, pacing should be completed from the coronary sinus ostial bipoles or coronary sinus 9-10 seen on the screen here. At baseline, the atrial signal shows conduction both through the CTI and around the top of the tricuspid valve. For the ablation, the radiofrequency generator is programmed to the desired settings. In this case, using an open irrigated tip catheter, 30 watts was used. The ablation catheter is placed into the right ventricle and then drawn backward until atrial electrograms are seen. The catheter should be at about 6 o'clock in the left anterior oblique projection, as more medial positions lead to a higher risk of heart block. The catheter is kept in position for 30 to 60 seconds, and a reduction in the atrial electrogram amplitude is seen. The ablation catheter is then pulled back a small amount until a new atrial electrogram signal is seen. This process is repeated until the inferior vena cava is reached or a line of block is seen. Several maneuvers are possible to ensure the ablation has created a complete line of block. During ablation, a change in the atrial activation pattern should be seen. There should be an abrupt increase in the conduction time across the CTI. In this case, the coronary sinus is on the medial side of the CTI and the Duo 5/6 catheter is on the lateral side. Initially, the time across the CTI with coronary sinus pacing is 110 milliseconds. When there is block across the line, it abruptly increases to 151 milliseconds. Pacing can then be completed from the lateral side of the CTI near Duo 5/6. Pacing from the ablation catheter just lateral to the ablation line should yield a longer time to the coronary sinus ostium, 163 milliseconds here. The ablation catheter is then raised higher up the lateral wall further from the ablation line, near Duo 7/8, and the time to the coronary sinus ostium should be shorter, 148 milliseconds in this case. The ablation catheter is again raised to a higher lateral position further from the ablation line, near Duo 9/10, and the time to the coronary sinus ostium should be the shortest, 140 milliseconds here. Another maneuver to ensure there isn't slow leak across the ablation line is to measure the time from the atrial electrogram at the His position to the atrial electrogram at the coronary sinus ostium. This should be the same whether pacing at the low lateral right atrium, seen on the left, or pacing in the high lateral right atrium, seen on the right. With both, the time is 41 milliseconds. In addition, when pacing medially, there should be a reversal of electrogram polarity on the bipoles lateral to the line, or Duo 5/6 here. Note how the electrogram is positive, then negative before CTI block on the left, but becomes solely negative when block has been achieved on the right. Ventricular pacing, if completed, will similarly show the atrial activation going up the AV node around the top of the tricuspid valve, but not through the CTI. After a complete line of block has been achieved, there is a waiting period between 20 and 60 minutes to confirm that block is still present, and the pacing maneuvers are repeated. Once the waiting period has been completed, the catheters can be removed from the body. The sheaths are then removed with manual hemostasis obtained. All cables and drapes are removed from the patient. The patient is then transferred to a stretcher. It is important not to bend the legs for 4 to 6 hours after the procedure to prevent the development of hematoma. The procedure is then complete.